Assalamu alaikum, dear students. This is our new topic we will discuss today. This is subacromial impingement syndrome. इस लेक्चर में हम बात करेंगे initially about that what are the types of different impingement, जो internal impingement है, external impingement या interior posterior impingement है, उसकी थोड़ी बहुत हम बात करेंगे और उसके बाद हम जाएंगे toward the specifically subacromial impingement syndrome. तो उसकी मैकेनिज्म पर बात करेंगे, उसकी काज़ पर बात करेंगे और नेक्स्ट सेशन में इंशाल्लाह दिन वी विल डिस्कस द एग्जामिनेशन एज वेल एज द रेडियोग्राफिक इन्वेस्टिगेशन एंड द ट्रीटमेंट ऑफ द subacromial impingement. Shoulder impingement syndromes, they can be broadly divided into external and internal type. These external, internal, they are the broad classification. They have further classification. Yeah, we can say that further examples of the external and internal type. The external impingement, they result from the abnormal contact between the humeral head and extra-articular structures such as the acromion or the coracoid process, thus leading to the subacromial or subcoracoid impingement. It's very important that which structures, osseous structures are involved. Here it is the humeral head, which is the superior surface of the humeral head, and the above, that is the acromion or the coracoid process are just below that. So it means this impingement, which is between the humeral head and this acromion process, that's why that is also known as the subacromial or subcoracoid impingement. These are the two, we can say that the subclassification of the external impingement. If it is below the acromion, so subacromial. If it is below the coracoid, so subcoracoid impingement. On the other hand, the clinical manifestation of the internal impingement, which commonly affect the overhead throwing athletes, in which there is involvement of extreme external rotation. So involves structure located between the humeral head and the glenoid. Now this is the important point. In internal impingement, the same structure is the humeral head, but the opposite structure is not the acromion or the coracoid, but it is the glenoid rib. It can be separated into posterior superior and anterior superior subtypes. These are the subclassification of this internal impingement. So the subtypes of the subclassification of the external impingement was into the subacromial impingement or the subcoracoid impingement, while the internal impingement is divided into two then subtypes, that is the posterior superior impingement or the anterior superior impingement. Now, what we mean by this posterior superior and anterior superior impingement? Posterior superior impingement concern the posterior supraspinatus and interior infraspinatus tendon as well as the adjacent capsule and bursa. While in the anterior superior impingement concern the subscapularis tendon and interior humeral head with the anterior superior glenoid and lumbarum during the forward flexion of the arm. So if we compare these two, here we have the two tendons, the infra and supraspinatus tendon, in which the supraspinatus posterior and the infraspinatus anterior portion, they may be involved, they may be impinged in the posterior superior impingement. While in the anterior superior impingement, the impingement is of the subscapularis tendon and the interior humeral head with the anterior superior glenoid and lumbarum when there is forward flexion or elevation in the sagittal plane. So some of the classification of the shoulder impingement and their etiology and other hallmarks of them. So सबसे पहले जो है interior subacromial impingement की अगर हम बात कर लें, the causes are soft tissues जो fill करते हैं subacromial space, जिसमें almost there are 6 structures, जिसमें से subacromial bursa आती है, supraspinatus tendon आती हैं, long head of bicep tendon आती हैं. So they are chronically entrapped between the humeral head and the coracoacromial arch, जिसमें से दोनों आ जाते हैं subcoracoid और subacromial. और ये structures है which may be impinged, and most important, this is the supraspinatus tendon, which is going to be impinged between these two osseous structures. Near describe a three-stage progression, which we will discuss in the upcoming slide. And today, this is our main topic. The subacromial impingement is our main topic. So we will discuss the three stages, or the three types and four types of the subacromial impingement. Stages जो है ये अलग बात है, ये three stages है, while types ये अलग है, there are four types, और दोनों को जो है हम near stages भी कहते हैं और दूसरे को near types कहते हैं. So progression from the impingement to and in severe cases when there is tendon tear, tendon rupture of the or these rotator cuff muscles. Several variation in tear acromioplasty has been shown to have good result. Acromioplasty, which is one of the main surgical procedures used in such condition, and when there is shedding of the that extra or abnormal acromion. This acromioplasty surgery, and this is also known as the subacromial decompression, और नीर ने इसी एक्रोमियोप्लास्टी या सबैक्रोमियल डिकम्प्रेशन को जो है उन्होंने इसमें यूज किया था. तो वो ये टर्म जो है वहाँ पे जो इनकी टाइप्स है, टाइप 1, 2, 3 एंड 4 टाइप्स ऑफ सबैक्रोमियल इम्पिंजमेंट, तो उसमें भी जो है ये सबैक्रोमियल डिकम्प्रेशन जो है इसका जिक्र हुआ है. तो ये उसकी बहुत अच्छे रिजल्ट आते हैं इन द इंटीरियर सबैक्रोमियल इम्पिंजमेंट. The other type is the posterior superior glenoid rim impingement. And the causes of this posterior superior glenoid rim impingement is the compression of the inner fibers of the rotator cuff and the fibers of the posterior superior labrum. And ये किसके दरमियान ये compression होती है? Between the greater tuberosity and the posterior superior glenoid. A situation between repetitive motion and impingement syndrome has been seen in patients involved in throwing sports, are top level water polo players. Throwing sports में we can see इसमें जो pitches है they are mostly उसमें common होती हैं. Pitches के अलावा जो डेक्स थ्रो हो गई या इवन इन क्रिकेट हो गई, जितनी भी जो है जिसमें ओवरहेड थ्रोइंग जो है होती है उसमें ये होती है. और इस तरह टॉप लेवल वाटर पोलो प्लेयर में भी जो है ये एक ही सिचुएशन जो है ये रिपीटेटिव मोशन और इम्पेंजमेंट सिंड्रोम के दरमियान पाई गई है. इसके अलावा जो फोर लेग ड्राइवर्स उनमें भी जो है ये कंडीशन जो है कॉमन जो है देखा गया है. फोर लेग ड्राइवर से मुराद वो छोटे ट्रक होते हैं जो किसी कंपनी या मैन्युफैक्चरिंग कंपनी की जो स्टोर रूम में होते हैं, जिसमें से बहुत एक जब प्रोडक्ट बन जाती हैं तो उसको एक जगह से दूसरी जगह ले जाने में ये वो छोटे छोटे ट्रक बने होते हैं जो बिल्डिंग के अंदर जो छत के अंदर जो है हाल में एक जगह से दूसरी जगह जो है सामान लेके जाते हैं, तो उस छोटे से ट्रक को कहते हैं फोरलिफ्ट कहा जाता है. तो उनमें भी जो है ये कंडीशन जो है देखी गई है. इसके अलावा जो बाकी जो टाइप्स है स्पेसिफिकली दैट सब कोराकाइड इम्पेचमेंट. This impingement may result from the posterior elevation of the humerus in a plane of 30 degrees from the frame combined with the internal rotation. And this is important. Subcoracoid impingement is that elevation combined with the internal rotation. And subcoracoid impingement continues contact between the coracoid tip and the most prominent part of the lesser tuberosity. ये उसमें होती हैं और उसकी वजह से जो है ये इम्पेचमेंट की चांसेस होती हैं. सर्जिकल इंटरवेंशन पॉसिबल है और इसके अच्छे रिजल्ट्स भी रिपोर्ट हुए हैं. Other type of shoulder impingement syndrome is the suprascapular nub impingement syndrome, which is actually encroachment of the subscapular nub. Here, there is no such impingement of tendon or ligaments or capsular structures. There is nub which is being encroached here. Calcified or hypertrophic splenoglenoid ligament and excessive nub angulation when it curves the infraspinous fossa are important pathogenic factors. We discussed these structures in the previous lecture when we were discussing the shoulder dislocation. What we mean by the splenoglenoid ligament, That is that ligament which is supporting the sphenoidinate notch. और यहाँ पे जो है फिर ये सुपरस्किपुलर नर्व जो है ये निकलती है। तो अगर वहां पर इसकी इस लिगामेंट की हाइपरट्रॉफी होती है या इसमें कैल्सिफिकेशन होती है, so obviously then they will encroach the suprascapular nerve that will compress this nerve. और when इसमें जब इस होगी तो इंक्रोचमेंट होगी तो इस नर्व की जो एक एंगल के साथ ये नीचे आता है, तो इसकी ये जो एंगुलेशन ये थोड़ा सा ज्यादा होगा, और जिसकी वजह से इसकी जो है इम्पेजमेंट हो सकती है, which will be called as the suprascapular nerve impingement syndrome. So this is that splenoglenoid ligament. This is that notch which is known as the splenoglenoid notch. This is the suprascapular nerve. ये यहाँ से निकलती है, यहाँ पे ये एक ब्रांच दे देती है छोटा सा जस्ट अबव द दैट स्पाइन। इस नॉच में से एंटर होने से पहले जो है यहाँ पे एक ब्रांच दे देती है टुवर्ड्स दैट सुप्रास्पाइनेटस मसल, और यहाँ पे फिर इंफ्रास्पाइनेटस मसल को भी ये सप्लाई दे देती है। क्योंकि इसकी इस नर्व की कंप्रेशन इस उसमें यहाँ पे होती है, स्प्लेनोग्लिनाइड लिगामेंट की हाइपरट्रॉफी या कैल्सिफिकेशन की वजह हो जाती है। दैट्स व्हाई इसमें जो प्रॉब्लम आ जाती है, सो दैट इज विद द this muscle which is actually the infraspinatus and not with the supraspinatus which is involved, which is innervated by the small branch above this impingement. So this is an example of that posterior impingement syndrome, the suprascapular nerve impingement. This artery is suprascapular artery. The subacromial impingement syndrome, which will be discussed in detail today. हमने टाइप्स डिस्कस की, इन सब में से हम ब्रीफली हमने उनके काजेस पे बात की, उनकी थोड़ी सी हमने उसकी मुख्तलिफ सिचुएशन पैथोजेनिक और मैकेनिज्म पर बात की। आज अभी हम जो है स्टार्ट करेंगे जो डिटेल, दैट इज आप जो SIS subacromial impingement syndrome, also known as the suprahumeral impingement syndrome, also known as the anterior impingement syndrome, or also known as the external impingement syndrome. The clinical external impingement condition characterized by the chronic anterior shoulder pain. This is important. In the impingement syndrome, specifically the subacromial impingement syndrome, what is the site of that pain? That is the anterior shoulder pain, is situated with limited range of motion, and specifically that pain, anterior shoulder pain, is exaggerated, is increased with the internal rotation of the shoulder joints. Subacromial impingement syndrome that results from the irritation of the tendon of the rotator cuff muscle and the subacromial space. And which tendon of the rotator cuff? This is mostly the supraspinatus tendon in the subacromial space, and may be due to an increased upward pulling force on the humerus or the scapular malposition. Subacromial space that lies between the coracoacromial arch and above and the humeral head and greater tuberosity of the humerus below. इस स्पेस की जो कैपेसिटी होती है, that is almost 1 centimeter or some plus some millimeters, जबकि यहाँ पे जो मोमेंट होती है, the maximum moment, the maximum translation of the humeral head, that is almost 5 mm. So अगर नॉर्मल स्पेस है तो एक ह्यूमरल हेड जो है बहुत आसानी के साथ उसमें ट्रांसलेट जो है कर सकती है, अगर जितने भी हम इलिवेट करें, the maximum if it is translated superiorly and medially, so that is up to 5 mm. But the space is 1 centimeter, so there will be no such problem. But due to because of that, sometimes most commonly this is the that abnormal structure of the acromion type 3 acromion, which is the hooked acromion, उसकी वजह से इस स्पेस की जो है स्पेस कम हो जाती है, और कितनी कम होगी, सपोज अगर ये 7 mm से कम हो जाती हैं तो फिर इट विल बी अ cause for the it will lead to the subacromial impingement. So it means the minimum space between this coracoacromial arch and that humeral head, they should be 7 or more than 7 mm. It contains the rotator cuff tendons, और not only the rotator cuff tendon but कि इसमें long head of bicep भी होती हैं, the shoulder joint capsule होती हैं, the tendon ligament, coracohumeral ligament, and as well as the subacromial bursa. So in 1934 ये जो impingement syndrome है, इसकी हिस्ट्री क्या है कि 1934 में Codman described the rotator cuff pathology. According to his opinion, humeral head and acromion impingement during shoulder abduction was the cause of rotator cuff lesion, and he suggested that the lateral acromioplasty would resolve the patient's symptom because, according to him, the most of the cases that is just because of that abnormal hook type of the acromion. So, if subacromial decompression or that acromioplasty, that may be the successful option to treat this condition. Then in 1972, Neil coined the term impingement syndrome, and he was of the opinion that impingement occurred anterolaterally at the anterior acromion and the coracoacromial ligament. Subacromial impingement syndrome, which is known as the SIS shortly, subacromial impingement syndrome, are also known as the SIS subacromial impingement syndrome of the shoulder, is probably the most common disorder of the shoulder and accounts for about 48% of all shoulder complaints, according to that study which was reported in 1972 by the Neil. So what is that subacromial impingement syndrome? Subacromial impingement syndrome is a condition where the subacromial space, the area directly below the acromion process and above the shoulder joint, is narrowed. This condition is also known as the external impingement syndrome or anterior impingement syndrome or suprahumeral impingement syndrome. This can happen for several reasons, traditionally categorized as either primary or secondary causes. अब ये हमने कहा था कि इंटरनल एंड एक्सटर्नल इम्पेजमेंट सिंड्रोम, फिर वहाँ पे इंटरनल की भी सब टाइप्स थी, एक्सटर्नल की भी सब टाइप्स थी, और ये जो subacromial impingement syndrome है, that is one of the type of those external impingement syndrome. लेकिन खुद जो है यहाँ पे and the basis of its causes, the subacromial impingement may be primary subacromial impingement syndrome or secondary subacromial impingement syndrome. These classification of primary and secondary is based on these causes. The primary causes are structural changes or the morphological precondition of the acromion process. So if there is something wrong with the structure of the acromion, that may be type 2 or type 3, they are the abnormal, specifically the type 3, which is the hook type, then that will be called as the primary subacromial impingement syndrome. So these are the three types. A normal type of the acromion. This is the clavicle. This is actually known as, that is flat. Acromion, the undersurface is flat. This is curved, and this is the hooked, which we call as the almost no space. Yeah, if there is very less space, there is hooking at the end. This is type 3, which is known as the hook acromion. That may be the cause of that subacromial impingement syndrome. और यहाँ पे जो है likelihood of impingement that increases because almost no space, and that is the type 3 hooked acromion. यहाँ पे acromion process curved होती हैं, a little less space होती हैं, and very less chances of the acromion. यहाँ पे चूंकि flat होती हैं, space ज़्यादा होती हैं, so there is no association of the type 1 with the subacromial impingement syndrome. So if the impingement syndrome is just because of this abnormal structure of the acromion, then it will be called as the primary subacromial impingement syndrome. Secondary sub-impingement syndrome, they may be because of the multiple multiple causes like the rotator cuff syndrome, tendinopathy, or inflammation, or the other tendons like the long head of the biceps, may be the cause behind this condition. The rotator cuff syndrome, which include both the grade 1 or the grade 2, 3 tier. The grade 1 is simply known as the strain, while the grade 2 or grade 3 tear, they are called as the tear, partial tear or complete tear of the muscle at the tendons of the muscle making up the rotator cuff. तो इसकी वजह से भी जो है ये सबक्यूबिक इम्पिंजमेंट सिंड्रोम हो सकती है। इस तरह जो मुख्तलिफ टेंडन डिसऑर्डर्स होते हैं इंक्लूडिंग द टेंडनाइटिस और टेंडनोसिस। टेंडनाइटिस जो है दिस इज द इन्फ्लेमेशन ऑफ द टेंडन, while tendinosis जो है दिस इज द degeneration of the tendon. If this tendonitis or tendinosis in one of the in one of the muscle of the rotator cuff among the infraspinatus, supraspinatus, subscapularis, so they may also lead to also that secondary sub-impingement syndrome, subacromial impingement syndrome. Inflammation of the subacromial bursa, which is the bursitis, also we have discussed them in detail. That and in that lecture we have discussed that subacromial bursitis is a strong association with the subacromial impingement syndrome. The long head or the tendon of the bicep brachii can also be involved. Subacromial impingement syndrome now include a spectrum of subacromial space pathologies, which include just a group of disorders that is not a single condition, and different conditions which can be that spectrum में क्या pathologies आती हैं that involve the rotator cuff tears, specifically the supraspinatus tendon, the calcific tendonitis. Again, this calcification is more common in the tendon of the supraspinatus tendon, bicep tendinopathy, rotator cuff tendinosis, and the subacromial bursitis. The subacromial impingement syndrome has been described as a group of symptoms rather than a specific diagnosis, and that's why it is a group of pathology. So we can say that a number of symptoms that may be present here. It is not a single diagnosis. The underlying cause may be among the structures which we discussed in the previous slide. There may be primary and secondary, but overall, if the cause is primary or secondary, it will be termed as subacromial impingement syndrome. Internal glenoid impingement, this is another type, and most probably this is the most common cause of the posterior shoulder pain in the throwing of the wounded athlete. In subacromial impingement syndrome, mostly the pain is in the interior side, but if the pain is in the posterior side, then the most common cause behind that in the throwing athlete is the internal glenoid impingement. This internal glenoid impingement, they may be caused by the impingement of the articular surface of the rotator cuff, specifically the posterior edge of the supraspinatus and the interior edge of the infraspinatus against the posterior superior glenoid and glenoid labrum. In this impingement syndrome, there is chances of impingement of both the supraspinatus and the infraspinatus. But in the subacromial impingement syndrome, in the most cases, there is chances of the impingement of the subacromial tendon or muscle. Mainly seen with repetitive overhead activities, pathologic during excessive external rotation, specifically that cocking and late cocking of the throwing phase, anterior capsular instability, scapular muscle imbalances, and are upon the repetitive overload of the rotator cuff musculature. Scapular muscles से मुराद जो है that is the scapula की जो upward rotator है and downward rotators है, इनमें imbalance आ जाती है. ओवरऑल अगर हम बात कर ले कि ऐसे क्या काजेज हैं जो शोल्डर इम्पिंजमेंट सबक्यूबिक इम्पिंजमेंट सिंड्रोम उसकी वजह से हो सकती हैं. So all those causes they have been divided into two main groups, that is the intrinsic and extrinsic. Mechanism of rotator cuff pathology these are the two main group of the etiologies of the subacromial impingement syndrome. It is not clear yet if the damage to the rotator cuff tendon lead to the impingement or if the impingement causes the damage to the tendon. Some theories argue that the poor vascularity of the supraspinatus tendon insertion could be a significant factor in the pathogenesis of the degenerative ruptures. And the supraspinatus SSP mean, the S mean supra and SP mean spinatus. Similarly, there is ISP, which means infraspinatus. So the supraspinatus mainly derived its blood supply from the interior circumflex humeral artery, and as well as also it derives its supply from the suprascapular arteries. But there is a specific zone near its insertion. And how much near it is insertion? This is almost 10 millimeter proximal to the insertion of this tendon with the greater tuberosity. And just near to that 10 millimeter proximal to that insertion and the greater tuberosity, there is a avascular area which is known as the critical zone. This critical zone, this is have a many shape that may be a crescent shape, they may be hemispheric shape, and they may be sail shape. But among these, this critical zone, and that is in most of the case, this is crescent shape. So if we can say the most common type shape of this critical zone is the crescenteric, while it may be very rarely it may be the sail shape, and very less is it the hemispheric shape. The length and width of this critical zone, they appeared markedly increase in the male individual, while increase in age may account for the increase in status of the rotator cuff degeneration due to the poor vascular supply. This critical zone, this is also known as the watershed region. So if the age is increasing and the person is male, so there will be high chances of the that um, pathology of the tendon. So just because of this critical zone or this watershed region, this is the area जहाँ पे जो है tendon की rupture भी होती है, tendon की inflammation भी होती है, और यहाँ पे इसकी वजह से जो है आगे जाके ये इसकी impingement हो जाती है. Intrinsic factor affect tendon morphology and performance over time. These factors are influenced by genetic predisposition, age-related changes, poor vascularity, biological alteration, and mechanical properties where the physiological limit of the rotator cuff tendon are suppressed. Poor vascularity पर हमने बात की कि वहाँ पे कुछ एरिया ऐसी होती हैं जहाँ पे ब्लड सप्लाई बहुत कम होती है. दिस इज ऑलमोस्ट बिल्कुल नहीं होती. एविस्कुलर जोन होती है which is known as that critical zone or that watershed region. तो उसकी वजह से भी जो है ये जो है टेंडन पैथोलॉजीज हो सकती है. एज के साथ जो है भी ये वेरी कॉमन होती है. सुपरस्पाइनाइटिस, टेंडनाइटिस या टेंडनोसिस, they are very common in patients with having 60 plus age. Similarly, there may be some biological alteration which we will discuss in the upcoming slides. Extrinsic factors relate to the anatomical structure and are the biomechanical alteration causing mechanical compression. अब anatomical structure में क्या क्या आते हैं? इसमें the various shapes of the acromion, जिसमें हमने discuss किया कि there are 3 types of the abnormal acromion, including the type 1, which is known as the flat, type 2, which is known as the curved, and type 3, which is known as the hooked. And among these 3, the type 3 has more chances of that impingement syndrome. While the other anatomical structures, which may be the extrinsic factor for this impingement syndrome, that is the osteoarthritic spurs on the subacromial as well as on the sub and the acromioclavicular joints. The biomechanical alteration that refers to the superior translation of the humeral head and altered scapulohumeral kinetics, often caused by a weakness and imbalance of the rotator cuff musculature or tendons. What we mean by the alteration in the shoulder kinematics is the alteration in the shoulder kinematics that are often observed among patients with subacromial impingement syndrome. The most common documented deficit, which we could call as the biomechanical alteration, are that alteration in the shoulder kinematics. They are the alteration in the scapulothoracic kinematics, the humeral head displacement within the glenoid cavity, and as well as the increased elevation and retraction of the clavicle and the sternoclavicular joint during the arm elevation in the forward direction. So causative factors include a trauma, rotator cuff dysfunction, tightness of the posterior capsule, which may lead to that gut disease, which is that humeral internal rotation deficit, postural abnormalities, scapular dyskinesia. Scapular dyskinesia that will be discussed in the coming slide. There are subtypes, other types of the that scapular dyskinesia and what these types mean. So discuss with along with images. Repetitive use, specifically this repetitive use the cause of that subacromial impairment syndrome among throwers and other sports activities in which there is overhead throwing. Glenohumeral instability, wear and tear and age-related degeneration, scapular muscle weakness and dysfunction, imbalance between the concentrically activated agonist and eccentrically activated antagonist. The silent symptoms that are the diffuse pain and pain on the palpation of the subacromial space, bicipital groove, and supraspinatus insertion. There may be limited range of motion, both the active and passive may be limited, and the presence of painful arc is very common in patients with subacromial impairment syndrome. And the painful arc means even if we ask the patient to abduct the arm and the side as far as he or he can, so up to the 60-degree there will be no pain, but after the 60-degree there will be the patient will complain of pain, and that pain will increases as he she go further in the abduction, and up to 120 there will be there will be maximum pain, but going beyond 120 there will be decreasing the pain. So if the pain is present in that arc, which is known as the 60 to 120 pain arc, then this is again a very strong indication of the subacromial impingement syndrome. Now, why there is no such pain in the 120 and below 60? So in the 120 up above 120, there is no such tension, and there is no such superior translation in the space. So because of that, there is no that narrowing of that space. इसकी वजह से जो है कंप्रेशन नहीं हो पाती और देयर इज नो पेन. सेम कहानी जो है इट इज बिलो 60 कि वहां पर जो है ह्यूमन हेड जो है इतना ट्रांसलेट अभी तक नहीं हुआ है कि वो इम्पेजमेंट जो है ये काज कर सके. इसी तरह जो है अदर साइन सिम्टम्स जो है दे विल बी decrease of strength, specifically in the external rotators, and on the other hand there may be very less strength deficit in the internal rotators. There might be tightness in the posterior and inferior capsule. Most commonly, the tightness is in the posterior capsule. So these are some of the characteristics of pain. These are the properties of pain, and then these are the scenario that what if there is night pain when the patient is lying on the affected side, and there is also muscle atrophy, so it indicates that the rotator cuff tear is present. But if the age is less than 30 year, it means the causes of this is biomechanical and there is tendonitis as well. But on the other hand, if the age is more than 45 years and there is again a history of a trauma, so then there is chances of the rotator cuff tears, which may be present in 35% of the patients. Painful arc, as we discussed in the previous, that would be present between the 60 to 120-degree abduction. There will be no pain before 120 and no pain. There will be no pain just below 60-degree abduction and no pain when the person go beyond 120 in the lateral abduction. And if there is the pain arc is present, the pain is present between 6 to 120, that is indicate that the person is having subacromial impingement. And if the pain is there beyond 120 abduction, then it indicates that the problem is in the AC joint, the acromioclavicular joint is the pathological site. If there is catching, popping, or clicking, some sound during this abduction of the shoulder joint, it indicates that there may be glenohumeral or the acromioclavicular joint arthritis, and there may be it also indicates that there may be labral tear. Now, what are the stages of the that subacromial impingement syndrome? So near classification इसको कहते हैं, और according to the near classification, there are three stages of the subacromial impingement syndrome. According to the near पहले stage में edema होगा, hemorrhage भी होगा, or all these conditions may be reversible, and mostly the patients of the participant of that, the patient is less than 25 years. So such edema and hemorrhage, they would be occurring in the young population. On the other hand, stage 2 may there will be then, instead of hemorrhage and edema, there will be fibrosis and tendinitis, and this mostly occur when mostly the patient are in the age between 25 to 40 years, and recurrent episodes of the pain may occur, or there will be increase in pain, specifically with the overhead activity. In the stage 3, bone spurs and tendon ruptures may appear, and this tendon rupture and bone appearance is very common and with the shoulder pathology in patients who are above 50 years. Are they are above 40 years, and there will be in the if they are not treated and they are left untreated, so these conditions they may progress into some lifelong disability. Similarly, there are four types of the class subacromial impingement, which again known as the near classification. और नीर ने जो यहाँ पे जो अभी हमने कहा कि एडीमा होगा, हेमरेज होगा 25 years से, ये तो इसी को उन्होंने यूज करके यहाँ पे 4 types of the subacromial impingement है, and these types जो हैं इसमें ट्रीटमेंट ऑप्शन भी इन्वॉल्व है कि कौन सी ट्रीटमेंट इसमें जो है ये बोन स्पर्स है, फिब्रोसिस है, टेंडनाइटिस है, एडिमा एंड हेमरेज, ये सारे फैक्टर्स जो हैं इसमें डिस्कस किए गए. So there are 4 types of the subacromial impingement syndrome according to the Neal classification, and these are known as the type 1, type 2, type 3, and type 4. In the type 1, usually the patient, they are less than 25-year-old, they are young patient, the concern syndrome, they are reversible, there may be swelling, tendonitis, mostly they are in the traumatic and acute cases. There will be no tear of the tendon, and usually conservative treatment will be effective, and the patient will give response to such treatment. In the type 2, again, the patient will be not too old. They will be mostly between the 25 and 40 years. Permanent scarring hogi, tendonitis hogi. Again, there will be no tears, but here that would be not possible to control it with the conservative treatment. So might be there is need of the subacromial decompression. Subacromial decompression that would be present in type 2, 3, and 4 as well. This is same term which we discussed previously, that subacromial decompression, which is actually the shedding of that extra acromion, abdominal acromion, which is also known as the acromioplasty. In the type 3, the patient will be more than 40 years. There may be some small rotator cuff tear and small acromial decompression with debridement repair, that would be very successful. On the other hand, the patient will be the same 40 years old, but the rotator cuff tear will be now large, and the subacromial decompression with repair that would be present. यानी the patient जो है इसको अच्छा response देगा. तो ये जो है, these are the types of subacromial impingement, and previously जो हमने discuss किया that were the stages of the subacromial impingement syndrome. Now, what are the mechanism of the Subacromial impingement syndrome. So two important primary pathways and one less common pathway have been reported in the literature. The two common important pathway which elaborate the mechanism of the subacromial syndrome, they are the posterior capsular tightness, and the second one is the rotator cuff insufficiency. And the other pathway, the less common, this is the mechanism, is the anatomic anomalies and the degenerative changes. So सबसे पहले हम posterior capsular tightness पर बात करेंगे, and then we will discuss the rotator cuff insufficiency, anatomic anomalies पर फिर बात करेंगे. अगर हम नॉर्मल एबडक्शन एलिवेशन की बात कर ले, तो ड्यूरिंग दैट नॉर्मल एबडक्शन और नॉर्मल एलिवेशन द ह्यूमन हेड रिमेन्स सेंटर्ड एंड रोटेट डाउनवर्ड. वाइल अगर इसके ट्रांसलेशन की बात करें तो इसकी ट्रांसलेशन जो है ये सुपीरियर एंड मीडियल होती है. So and it rotate downward in the glenoid cavity while the scapula rotate superiorly around the horizontal axis perpendicular to it. Internally, which means around a vertically through a plane and tilt posteriorly, the healthy rotator cuff, the legs, PC, and the axillary recess, healthy musculature around the scapula, they would be present in the normal abduction and elevation. But if there is some problem with the rotator cuff or the PC or axillary recess, so there may be then posterior capsule tightness. The PC means posterior capsule. अब इसमें से अगर पोस्टीरियर कैप्सूल टाइट है या इसमें से रोटेटर कप में प्रॉब्लम है या यहाँ की स्किपुला की जो सराउंडिंग मसल्स है, जो अपवर्ड रोटेटर्स है, डाउनवर्ड रोटेटर्स है, उसमें मसला है, तो इन तमाम सूरत में दे विल बी जो एबडक्शन इलिवेशन होगा ये सही तरीके से नहीं होगा, नॉर्मल होगा, एंड दैट may lead to the further manifestation which may lead to the that subacromial impingement syndrome. So these are those scapular muscles, the upward rotators, and sometimes if there is imbalance between these muscles, it will lead to the that biomechanical abnormalities which may cause subacromial impingement syndrome. So the upward rotators, they are the upper part of the trapezius. This is the serratus anterior to that area, and this is the lower part of the trapezius. If they are working synergically, so these are the upward rotators, but if they are working isolatedly, then this is the elevation of the scapula and this is the depression of this is the scapular elevator, and the lower part trapezius is the depressor. Here are the downward rotators of the scapula. So this is actually the rhomboid major and minor. Here these are the levator scapulae. So that levator scapula is arising and elevating this side, while the rhomboid major they elevating this corner, and the same time the pectoralis minor they are just moving it the scapula into this side, and it will rotate in the downward direction. Similarly, here the lateral side is being elevated by the upper part, while this portion is being depressed by the lower part, and this lower angle is then elevated in the by the serratus anterior, hence it is upward rotated. So the in तीनों muscles की synergic action की वजह से the scapula will rotate in upward direction. Here it will rotate in the downward direction. So for normal healthy orthokinematics and osteokinematics, and for normal that biomechanics of the shoulder joint complex, the balance between these muscles that is important. These are the movements. This is the downward and upward rotation of the scapula. This is the interior posterior tilting, while this is the external and internal rotation of the scapula. There is another movement which is one is hand behind the head, the other is the hand behind the back, and the third movement is the reaching up behind the back movement. This is actually the reaching up behind the back movement. This movement, RUTB, rising up behind the back movement, that composite of three movements: extension and internal rotation at the shoulder and flexion of the elbow. Here we can see that extension. This is extension because to reach to the back, we need the extension of the shoulder, as well as there is internal rotation, obviously, and then we need the elbow flexion to reach up the back. The humeral head rotates internally in the granite cavity and the scapula reaches to its end limit of the available ranges. Now this movement again require the normal and the balance between all the muscular of the scapula, including those six muscles in which there were downward and upward rotators. The glenohumeral internal rotation and deficit, which is one of the symptom or condition, which may be because of the posterior capsule tightness. There are consistent problems seen during the examination of overhead athletes, because among them there may be some adhesions in the posterior capsule which may lead to the tightness in the PC. The deficit in the internal rotation are attributed to the tight posterior capsule. Reaching up behind the back is important functional movement, and difficulty in this movement is the frequent complaint in patient with subincrement Impingement syndrome, and that reaching up behind the movement require the normal internal rotation of the that glenohumeral joint. But if the GERD is present, then glenohumeral internal rotation deficit is present, then obviously there will be no such reaching up behind the back movement. If the patient is asked to do that reaching up behind the movement and he can't do that, so it might be because of the most of the cases there is internal rotation deficit, and this indicate that the person may have tightness in the posterior capsule. Then this may be treated with some releasing exercises, the capsule releasing exercises, including the sleeper stretch, as well as the cross the body stretch. So in the person who having the tight PC, he or she will be unable to do the internal rotation completely on that side. But if the PC here is normal, so with the 90-degree abduction, the patient will move into the 90-degree of internal rotation. Here at the 90-degree of abduction, the patient will be unable to do that 90-degree of internal rotation. Isolated active internal rotation or extension of shoulder is often pain-free in most of the impingement cases. And combination of these movements in the reaching up behind the back nearly always produces anterior shoulder pain. A tightness in the capsule and adhesion with the fascia is probably allowing the uniplanar movement but opposes the torsional stress behind the reaching up behind the back movement. So what will be the consequences? If there is that GERD, glenohumeral internal rotation deficit, if there is failure of that reaching up behind the back movement, if there is posterior capsule tightness, so what will be the consequence? The consequence will be that the scapula will move abnormally. Or why it will move abnormally? Just to compensate the deficit in the glenohumeral internal rotation. And when due to this compensation of the scapula, due to this abnormal movement of scapula, they will be the more than movements, there will be unrequired movement. जो normally जो movement scapula को नहीं चाहिए वही movement वो करेगा because to compensate, and इस condition को फिर हम कहते हैं the scapular dyskinesis, the scapular dyskinesia, in which the movement of the scapula is abnormal. उसके पूरा डिस्काइनेसिया जो है दिस इज अगर हम बात करें कि उसकी डिफिनेशन क्या है, तो नॉर्मल ह्यूमन मोमेंट्स की जो एग्जीक्यूशन के लिए जो चीज़ ज़रूरी है वो ये है कि स्किपुला का नॉर्मल, नेट ओनली नॉर्मल से मुराद ये है कि वहाँ के जो सिंक्रोनस मोमेंट है, जहाँ पे अगर आप इलिवेशन करें तो शोल्डर की एबडक्शन भी चाहिए, शोल्डर की जो है वहाँ पे रिट्रैक्शन प्रोटेक्शन भी चाहिए, वहाँ पे उसकी अपवर्ड रोटेशन भी चाहिए विद द एलिवेशन। और ये जो 120 रेशो यानी 1 to जो रेशो है कि 120 अगर इसका ग्रीन ह्यूमरजेंट कंट्रीब्यूशन है, तो वहां पे फिर जो 60 डिग्री कंट्रीब्यूशन है, दिस इज द कंट्रीब्यूशन ऑफ द स्किपुला विच मेक द टोटल 180 ऑफ द ग्रीन ह्यूमरजेंट। तो यहाँ पे अगर इस सिंक्रोनस मोमेंट नहीं है, जस्ट फॉर द नॉर्मल ह्यूमन मोमेंट्स एग्जीक्यूशन के लिए, तो फिर हम इसको कहते हैं स्किपुलर डिस्किनेसिया। सो दिस डिसफंक्शन ऑफ द synchronous movement of that scapula is termed as the scapular dyskinesis. Non-specific response to a painful condition of a shoulder. This scapular dyskinesia is non-specific response. And shoulder pain dyskinesis, if present, is always present typical pattern during the arm elevation, and it is manifested as delayed upward rotation, posterior tilting in early internal rotation. And the most important thing is that early internal rotation. And because of that internal rotation, there may be some winging and there may be some problem to the that complete complex of the scapula. Reversal of this position of scapula significantly increases the subacromial space. So, but reversal of this position, if there is internal rotation, what will be that problem for the scapular complex, that shoulder girdle complex? Because of that early internal rotation, they will be decrease at the subacromial space, and that's why this upward rotation, posterior tilting, and early internal rotation combinedly, this delayed upward rotation and the early internal rotation will lead to the narrowing and decreasing of the subacromial space, which will lead to the subacromial impingement syndrome. So that's why the story is connected, that why the scapular dyskinesia, why the GERD, the green human there in internal rotation deficit, and the imbalance between the muscle of the scapula, that is how it is connected to the and is associated to the subacromial impingement syndrome. The subacromial space markedly reduced due to this movement of scapula. This movement से मुराद जो है ये delayed upward rotation, posterior tilting, and early internal rotation. This is that scapular dyskinesia. We can see here there is some prominency and winging of the scapula, and we also see that there is asymmetry of the shoulder as well. So on the basis of different prominence of the different parts of the scapula, the scapular dyskinesia can be divided into type 1, type 2, type 3. So in the type 1, there is prominence of the inferior medial scapular border. Here there is no such big prominency. This is not, but here that is prominent. We can see this prominence of the inferior mediascapular border. That is actually known as the type 1. Now, this is the abnormal rotation around the transverse axis. And what does it indicate? If there is type 1 scapular dyskinesia, it indicates that the weakness of the lower trapezius, the weakness of the latissimus dorsi, the weakness of the serratus anterior, are the tight pectoralis minor as well as the tight pectoralis major. In the type 2, this is the most common case. That's why it is also known as the classic winging. And there is prominency of the entire medial scapular border, abnormal rotation around the vertical axis, and indicate the weakness of the serratus anterior, rhomboids, and all fibers of the trapezius, including the upper, middle, and the lower trapezius. In the type 3, there is prominency of the superior medial scapular border with superior translation of the entire scapula. Here, this is the superior border. This is not the normal place the scapula should be there. So that superior translation and prominency of the superior border is the characteristic of the type 3 scapular dyskinesis, and it indicates the overactivity of the levator scapulae. The function of the levator scapulae is to elevate the scapula, but if this function is overactive, this muscle is overactive, so it will do more, and do more की वजह से जो है ये scapula जो है abnormally translate करेगा in the upward direction, which is the type 3 scapular dyskinesis. And imbalance of the upper and lower trapezius force couple, because if there is balance between the shoulder elevator and shoulder depressor, so there will be normal movement of the scapula. But if there is imbalance between this upward this elevator of the scapula and depressor of the scapula, they may also lead to that superior translation of the scapula. That in subacromial syndrome, there is some force couple during the elevation and abduction, and this force couple is between the different muscles, including the deltoid and as well as the members of the rotator cuff. There is force couple alteration within the members of the deltoid muscle. There are three part of the deltoid: the interior, middle, and posterior group. An altered force subcouple is also present between the serratus anterior trapezius, rhomboid, and levator scapulae. So when there is alteration of in these couple forces, so what will be the consequences? All these will lead to also that superior translation of the humeral head and repeated movement of cause tendinitis. So we discussed in the previous that there is imbalance between, so that imbalance is between the altered force couple of the serratus interior trapezius, rhomboid, and levator scapulae. If we talk about the muscle flexibility, so in chronic cases of the subacromial syndrome, the muscles, in specifically the pectoralis minor and the levator scapulae, along with the subclavius muscle, they are very tight and shortened. And these tightness and shortness of these muscles, they contribute to the reduction of the subacromial space, which further increase the risk of impingement. Now let's come toward the second mechanism, which was the rotator cuff failure. Before that, that was the PC, the posterior capsule tightness. So अगर हम इसको समराइज करें, हमने कहा कि when there is posterior capsule tightness, तो वहां से क्या होगा? इंटरनल रोटेशन डिफिसिट होगी. जब इंटरनल रोटेशन डिफिसिट होगी तो रीचिंग अप बिहाइंड द बैक या बाकी जो एलिवेशन ऑफ द स्कैपुला उसमें जो है ग्लेनोहेमोरोजैन की रोटेशन जो चाहिए होगी वो लिमिटेड होगी. तो उस लिमिटेशन को कंपेंसेट करने के लिए स्कैपुला को थोड़ा सा एक्स्ट्रा काम करना पड़ेगा. वो एक्स्ट्रा काम जो है उसका वो एक्स्ट्रा मूवमेंट है, एंड दैट एक्स्ट्रा मूवमेंट को हम स्कैपुलोडिस्काइनेसिस कहते हैं, जो पहले हमने डिस्क्राइब किया कि दैट इज अब टाइप 1, टाइप 2 एंड टाइप 3. The rotator cuff failure जो है, the contraction of deltoid will cause superior translation of the humeral head. Because deltoid जब contract होती हैं तो ये humeral head को superior की तरफ इस तरह translate कर देती हैं. At the same time, there are some muscles which will just counterbalance these translation, and these muscles are the rotator cuff and the long head of the bicep. So the rotator cuff क्या करती हैं? They compress the humeral head within that space, within that glenoid fossa, while the deltoid muscle, they will try to elevate and will try to translate superiorly the humeral head. So if there is a rotator cuff failure, so they obviously then this counterbalance will be disturbed. And when this counterbalance is disturbed, it means they will be prominency, they will be this more moment of the contraction of deltoid will be causing the superior translation of the humeral head, and this superior translation of the humeral head will lead to the narrowing and that stenosis of that subacromial space, which will further lead to the subacromial impingement. So rotator cuff failure that allow the superior translation. Why that allow? Because counterbalance is provided by the rotator cuff. If the rotator cuff they are weak, so there will be no counterbalance, and there will be superior translation of the humeral head. And repeated movements causes injury to the rotator cuff tendon, long head of bicep, and the subacromial bursa. And it is a vicious cycle. अब even से vicious cycle से मुराद ये है कि ये जो रोटेटर का फेलियर है, इससे होगा क्या कि ये विल बी सुपीरियर ट्रांसलेशन काज करेगा. सुपीरियर ट्रांसलेशन अपडेट जब बार बार होती है तो उससे रिपीटेड मूवमेंट, उससे रिपीट मूवमेंट से ये रोटेटर का और भी जो है इंजरी उसकी होगी, और जब इसकी इंजरी और होगी तो ये और भी जो है सुपीरियर ट्रांसलेशन होगी. इट मीन A is causing the B and B is causing the A. A is again causing the B and B is causing the A. इस तरह साइकिल जो है चलता रहता है. So this is actually known as the vicious cycle. So the outcome of the repeat injury may be partial or full thickness tear, and this is the end result. This further injury जो है causes of the rotator cuff ends when there is complete rupture of the this rotator cuff tendon, specifically the supraspinatus tendon. The third cause mechanism of the injury for that supraspinatus impingement is the anatomic anomalies and the degenerative changes. As we have discussed previously, that the normal space is the subacromial space is 1 to 1.5 centimeter, and the normal humeral translation is 1 millimeter to 5 mm, and that's why the normal space, which is 1 centimeter or 10 mm, and if it is 9 mm, 8 mm, it's okay. It's 7 mm, it's again okay. But if it is less than 7 mm, so then there may be chances of the subacromial impingement and significant translation compared to available space. Scapular dyskinesia and the resultant acromion tipping combined with subacromial structures and acromion anomalies with spurs, there is little room for error. So these are the sources of pain in subacromial impingement syndrome, which depend on the severity of the duration of the symptom. And these include the tendon of rotator cuff, long head of bicep, ये सब पेन दे सकते हैं. These all may be involved because we have discussed in the start that subacute impairment syndrome is actually a cluster of pathologies और उसमें बहुत सारी structures जो है involve हो सकते हैं. That is not a single diagnosis. और ये structures क्या क्या हो सकते हैं? ये रोटेटर कफ टेंडन हो सकते हैं, लॉन्ग हेड ऑफ बाइसेप हो सकती हैं, सबक्यूमियल बर्सा हो सकती हैं, डेल्टाइड मसल, बिली ऑफ द सुपरस्पाइनेटस एंड इंफ्रास्पाइनेटस, सबस्कैपुलरिस, rhomboids, major and minor, serratus interior region between the fascia and the that PCT and the neurogenic pain, all of are few of the above. So this is actually the story of all that vicious cycle. That if there is posterior capsule dysfunction, so it will cause the posterior capsule tightness, and this posterior capsule tightness will further cause the weakness of the rotator cuff. So rotator cuff dysfunction will causes the PC tightness, and PC tightness will causes the rotator cuff weakness. At the same time, if the PC is weak, so it will cause scapular dyskinesia, and this scapular dyskinesia will again will lead to the rotator cuff weakness. This rotator cuff weakness not only caused the capsular epicetatis, posterior and inferior capsular tightness, but it will also lead to the anterior superior translation of the humeral, because यहाँ पे जो हमने कहा कि काउंटर बैलेंस होती है डेल्टाइड हेड की, तो डेल्टाइड हेड काउंटर बैलेंस काउंटर रोटेटर कफ करती है. इफ देयर इज रोटेटर कफ वीकनेस, उसका काउंटर बैलेंस नहीं होगा. जब काउंटर बैलेंस नहीं होगा तो देयर विल बी इंटीरियर सुपीरियर ट्रांसलेशन ऑफ द ह्यूमरल. ये anterior superior humerus जो है, this is also because of the alteration in the fourth couple, which we have discussed in the previous slide, and that fourth couple is just because of the compensation of the scapula, and that compensation of the scapula is termed as abnormal movement of the scapula, termed as the scapular dyskinesia. So that abnormal movement of the scapula, that compensation of the scapula, known as the scapular dyskinesis, that will lead to the alteration in the fourth couple, and that force couple will then lead to the anterior superior translation of the humeral, as well as this will also causing the weakness in the rotator cuff dysfunction. Similarly, it will also lead to the subacromial impingement directly, or it may be the source of pain, or that may be the limitation in the mobility. If there is interior superior humeral translation, so that will lead to the reduction in the subacromial space, and that reduction in the subacromial space is also because of that abnormal compensatory movement of the scapula. This reduction in acromial space will call as the subacromial impingement syndrome, which will causing the pain and the relative immobility. The range of motion will be limited, and this pain and relative immobility will again cause the rotator cuff weakness, because there will be no mobility, there will be pain, and because of the pain, the patient will be unable to mobilize the shoulder joint, and hence it will lead to the tightness of the that posterior capsule. Posterior capsule tightness will again cause the rotator cuff weakness, and pain and relative immobility, which will cause the rotator cuff weakness, will further cause the posterior capsule tightness, and hence again the process will begin. So it is causing, A is causing the B, and B is causing the A, or this process is on. This process, when the A is causing B and B is causing A. This cycle is actually known as the vicious cycle. So this is some complex interaction of the key components and the vicious cycle of the subacromial impingement syndrome. The range of motion, the flexion in the forward direction is 180, in which the cranial hemorrhage contribution is only 120. Extension behind the back, this is 40 degree. Abduction is 180 with palms up. Adduction is 0 degree, is known as the adduction. External rotation, that is 45 arm inside, elbow flexed, and internal rotation 55 degree when the arm are at side and elbow flexed. That will be discussed in the next section, inshallah. Thank you so much to all of you. Have a nice day. Allah Hafiz.